Welcome to our latest episode of Leadership and Culture in Healthcare. I'm Matthew Winn, podcast host, and we are bringing our latest series on independent healthcare providers to an end. And I'm delighted to be joined by David Hare, who is going to kind of look back over the episodes that we've had about independent sector healthcare providers and just give some thoughts. David, why don't you introduce yourself, explain what your role is, how you came to do your job, and also the organization that you lead as well.
Hi, Matthew. Great to join you. Yes, so I've been leading the Independent Healthcare Providers Network now for over 10 years. The network is the representative body for the UK independent healthcare sector. We cover all 4 nations, which I think helps us bring quite an interesting kind of multi-country perspective to things. About half our members are private hospitals, but the other half is a really rich, diverse range of diagnostic providers, primary community care providers, a bit of mental health provision, and so on, because it is a really rich and diverse sector, £21 billion a year sector, small when compared to the NHS, but no doubt significant, when you look across the UK economy and employs about 160,000 people in England alone. Before this job, which I just about remember, I've been in this so long, I can just about remember a life before IHPN. I've always really been in and around kind of government and Parliament. I worked in Parliament for a number of years in my early 20s, and then joined a very small government relations and media agency and helped build that up into a top 10 UK firm, and exited that to join this organisation. Driver really being, I've always felt that independent healthcare has got a massive contribution to play to improving the health of the nation. I think we'd seen in the 2000s, under the what's now the previous Labour government, really good, sensible use of the independent sector to maintain free at the point of use healthcare provisions. So, was very kind of inspired to want to join, and 10 and a bit years on, I'm still here.
And just so people kind of get a flavour, what does a network do? I think I know because I've dealt with you and the network dealt with you. That sounds terrible, doesn't it? I've discussed with you in the past and the network when I was working in NHS England. But just give people a sense of what the network aims to achieve for its members and how that kind of operates as an organisation.
Yeah, so I think increasingly it's quite common for industries to have a trade association or representative organisation. I think for independent healthcare, it is, I think quite rightly, a very regulated industry. It's also a quite politicised industry, and therefore having a voice collectively to express what the views of the industry are is really important. I think we do that as robustly as we can. But I think, we have a bit of a slogan at IHPN, when done together, done through IHPN, there are so many areas where the industry, feels that collectively it's able to do more than individual providers are. And I'll give you a number of examples. During the pandemic, it would have been impossible, I think, for the government and for NHS England to have contracted with nearly 30 private hospitals separately in less than a week to deploy all of that resource to assist with the pandemic. Doing that through us, negotiating that and then organising that allowed that to be done much more rapidly. Obviously, we all hope we don't get another one of those anytime soon, although clearly that could come along. Net zero is another area where we do an awful lot of work. It isn't a point of competitive tension between the providers, learning from each other what is best practice, what have people developed, what have people done to help get their carbon emissions down, and we have vast majority of our members now signed up to a 2035 net zero commitment. And actually, even when war broke out in Ukraine, the industry came to us and said, look, we all want to help, but doing that individually is probably going to be too small. Can you connect up with the Ukrainian embassy in London to help us understand what we need? And we moved more than 1 million items of drugs. People were were put in, and support was given. And again, those sort of examples, there are many others where actually I think having a single point of access to an industry, acknowledging there's going to be variation in views, and our job is to distill that to a degree, but you can move much more quickly in a much more agile manner when you have an association that's able to do that.
Yeah, so really quite varied in kind of that regulation, lobbying, kind of getting the policy right, but also connecting people together. Okay. So, David, we're going to discuss for the rest of the podcast, I guess, just reflections from the episodes from your members. And we've had quite different, actually, perspectives from the connector around musculoskeletal care, Vitality, who are a insurer, but broader than an insurer, and then Ramsay Healthcare UK element, who provides ostensibly elective centres, or sorry, local hospitals, private hospitals, and do a lot of elective work for the NHS. And here, let me start with an observation and see how this chimes with the rest of your sector. So I listened to those leaders talk, and if I hadn't known that they were from an independent health sector background or leading those organizations, I could have been equally kind of convinced that they were providing a view on leadership that an NHS good leader would also talk about. And so that does beg the question. We talk about the differences in healthcare provision, but actually it's pretty much the same, isn't it? The nature of providing great healthcare is about standards, it's about people, it's about getting the patient what they need, but coming at it from different perspectives. What's your take on what you heard compared to the rest of the sector that you lead?
Yeah, so listening to Nick, to Andrew, and to Keith, I wasn't at all surprised by a lot of what they said and the conclusion that you've drawn there, because certainly when I talk to leaders in the independent sector, frankly, whether they deliver overwhelmingly NHS services or a minority service or NHS, the kind of the language they use about pursuit of quality, around the need to deliver what the patient needs, are no different to what NHS leaders want to achieve as well. I think we have an odd discussion sometimes in this country, and I'm fortunate in this job to travel and to talk to people in different jurisdictions, and one thing really sticks out to me, that you don't in most other jurisdictions have this sort of polarized divide between a public provider of a service and a private provider of service. There clearly are some differences, but it does seem to be particularly stark here, and I welcome, actually, I think, what's emerged in recent years, which is a bit of a cross-party consensus around the role of the independent sector and frontline service delivery. When I look at the data, the sector is now doing 1 in 5 of all inpatient and day case procedures, NHS-funded procedures, 1 in 10 of all electives, and over 1 in 4 of all NHS-funded scans. So it's and an awful lot of community services, as you well know, Matthew. So it's a pretty embedded part of frontline NHS service delivery, has been for an awfully long time, and therefore I think breeds a mindset amongst the leadership that is as committed, frankly, to delivering outstanding NHS care as those individuals in the public sector, because I don't speak to any leaders in the independent sector who do not believe in the fundamental principles of the NHS, free at the point of use, funded through general taxation, with an ambition to make those services as high quality as possible. I think the challenges are maybe slightly different to NHS leaders. I think sometimes the sector can find it more difficult to be at the heart of discussions around integrating care, and maybe feel a bit second tier in that regard. But actually, the mindset around making sure your organisation is values led, is people led, and is delivering outstanding NHS care is not something that surprised me at all.
And I guess for listeners to this, it's probably worth us kind of clarifying that some of these organizations in the independent sector will be doing private work, won't they? There will be private payers or insurance-based payers, and then that's subject to the vagaries and the machinations of that kind of price envelope and the cost elements. But a lot of them, so Connect are, I think, nearly 100%. In fact, I think they are 100% NHS funded. They're funded as a community musculoskeletal provider in a no different way than I'm funded as a community provider operating in east of England. And I think I'm right in saying, therefore, that people like Ramsey would be paid the same price for a hip and knee operation as the NHS would pay. And is that your kind of view? And is that true across the rest of the sector? Because people may have the impression that we're talking about a massive pay differential here.
Yeah, no, I mean, clearly the sort of funding arrangements will differ depending on what service you provide. So clearly, as you well know, Matthew, the sort of the way in which community services funded, often differs from the way, say, elective care or aspects of diagnostic care are funded. But fundamentally, if Andrew and his team at Connect are successful in winning a contract to deliver a pain management service or MSK service, either to an ICB or to a trust, it's at a price point specified by the ICB, and they've bid in that way and have had to demonstrate that they can deliver that service to a high standard. If you're Ramsey or a number of other independent sector acute providers, then you're paid the NHS tariff price that's set by the NHS on an annual or 2 yearly basis, and you take that price, and certainly the last couple of years, the NHS itself has, certainly for elective treatment, has been back onto what's sort of commonly known as payment by results, probably more payment by activity really, sort of basis. So you drive your income through that route, and I think it feels like that model has come back into vogue a bit in recent years, given the success of payment by results in the 2000s to incentivize driving up activity, albeit admittedly accompanied by hefty dollop of additional funding in that period of time, and certainly, when I look at innovation in the in the independent sector, often that innovation is around productivity and efficiency, as opposed to coming up with lots of whiz bang new ideas, because frankly, if you can treat more patients on a list safely and effectively, that's more patients getting the treatment that they need, but also in an activity-based system, it also drives up the activity and the income that you drive. So a good alignment of incentives. So there are definitely similarities between how the independent sector is paid and the NHS.
And on that kind of vein, I guess, David, I was expecting, and this may be my prejudice, but I was expecting a different approach in how independent health sector organizations might be led and how they frame. So this podcast is all about leadership. It's all about culture. It's about how that impacts on the delivery of care. But when I listen to Connect leader and I listen to Ramsey leader talking about their delivery of care, going back to my earlier point, their treatment of staff, their razor sharp focus on outcomes, the right thing for the person, the supporting staff in the very best way from onboarding all the way through, clear objectives. Again, that was all best in class kind of attitude of, if we treat our staff well and we're really great to them, we will provide great care. I had to say I was slightly surprised at that. I was thinking there would be a far more kind of dynamic on profit, and that would kind of be an overweighting kind of anchor almost. I don't know if you can have an overweighting anchor, but you get my point. And it wasn't that, and I was pleasantly surprised that it to me it sounded a little some really good healthy workplace culture that was driving great healthcare. Full stop.
Yeah, I mean, I'm lucky in my job to be able to get out pretty much every week to go and see an independent sector site somewhere in the country. And one of the first things that I try and do is to spend time with the staff, ask where they've come from, how do they find the service. I've never had any resistance from the leaderships of either those sites or the providers in having that very honest conversation. I'll let them know I'm planning on doing it. But, what I want to hear from the staff is, how does it feel to work in this provider? and whether they've been homegrown, always worked for that provider, whether they've worked for another provider in the independent sector, come from abroad, because like the NHS, we have a very kind of diverse global workforce in the independent sector, or in some cases have come from the NHS. I think there's an overwhelming sense that they are able to do what they love, what they want to do, which is to deliver great care to patients. Yes, of course, they need to do that in an efficient manner and are cognizant, I think, of the fact that they are working for, in the main, for-profit organisations. But, they are, very, very passionate about what they do. And I think looked at through the prism of the leaders in the sector, it's like anything. If you've got a really demoralized workforce who aren't giving, their best, then your service quality will drop. You will lose staff. It's a competitive environment, whether you're in the NHS or the independent sector. We don't own these people. They will make entirely rational and logical decisions for them and their families. And what we really don't want, which we've got too much of, is people leaving these isles to go and work abroad because they feel that they can't get what they need here. So it's incumbent, I think, on all providers to do as well as they possibly can. And of course, I see that in the NHS as well. The variation when you look at the NHS staff survey is huge. So I think it is that real emphasis on well-being, on support, on allowing them to just get on and do what they want to do, which is care for patients. That kind of comes through loud and clear. Certainly whenever I go and see people and meet people in the sector.
And I guess some of the notable failures in the independent sector around some sectors. So there's been some quite difficult ones around the mental health sector, hasn't there, and learning disabilities. I have to say, there's some of those mirrored within the NHS, of course, as well. And your point is, it's all about leadership. It's all about setting the culture and having a great board and having a right purposeful attempt. And that, I think, is universally applicable to the NHS world as it is to primary care, as it is to the independent sector in local hospitals, etc. It's all about that leadership approach. Let's focus on one other area then, David. So I thought Nick Costa was interesting. They're all interesting, just to be really clear. But Nick Costa was interesting in where he was going in parts of our podcast, and was talking about the partnership with the NHS. He viewed their local hospitals, their 37 units, as partners with the local NHS. But he started, and we didn't have time to delve into this, but it'd be interesting in your perspective. He started to then say, well, also that may mean that the dynamics and the relationship between the independent sector and the NHS need to alter. And I suppose if I think about that, I might think about training. I might think about, you've mentioned green, so the connection with the totality of the net impact on a local level and all those type of things. And maybe one of the arguments and one of the criticisms of the private sector is it hasn't been involved in enough, my language, grunt work up front, but it gets the benefit of workforce, it gets the benefit of all those other elements. How do you think, as a membership organisation, do you think that might change over the coming years if it's going to be a true partnership between the independent sector and local NHS organisations and ICBs?
Yeah, I think you ask a really good and important question there, Matthew. I think the emerging cross-party consensus and the notion that the sector is a core part of NHS service delivery, not just this year and next year, but over the long term. Now, of course, I would argue it has been, but I think the debate has been somewhat contorted, and I think there's a real opportunity now to establish as the norm a plural provider environment delivering frontline NHS services as one of the key ways of maintaining the thing that the British population want, which is a free at the point of use health service. They just want it to be, better than it is now. And I think that what I'm certainly seeing in the industry today is a response to that change, which is to say, okay, what do we therefore need to do in order to be part of that long-term? Training absolutely is one of those issues where the sector knows it does need to do more. We've established with the Royal Colleges, with NHS England, a group to look at this. We know there is much more training going on now in the sector. There are hurdles to that, no doubt about it. We understand the pressure that NHS trusts are under, and therefore releasing junior doctors, for example, to go and work with the consultant when they're doing some work in the private sector can be difficult because they need that warm body, that pair of hands back at base. But we're beginning to work through that. One of the areas where it's probably been most acute has been in ophthalmology, particularly in cataracts, because it's now the case that around 2/3 of NHS funded cataracts are done in the independent sector. Massive increase since the pandemic. A lot of new providers starting up. Brilliant for patients on one level, because it is meaning that I think ophthalmology is now the only specialty where the median waiting time is less than it was in 2019. So actually, from that perspective, great. But it's putting an awful lot of pressure on trainees back at base, because they need to be able to have the opportunity to learn on some of those, maybe slightly more high volume, low complexity services, procedures. So, we've agreed a sort of minimum set of time that juniors will be spending in the independent sector. Therefore, much more time training and learning. They love the environment. Whenever the colleges sort of poll, experience, it's always really positive. They're in a purpose-built, state-of-the-art new facility, getting using all the right kit, but now getting that opportunity. There's more to do, but absolutely right that the sector is pressured to continue to drive that forward. I think the other area that I would say is quality and safety. If I go back 6 years, a third of independent sector acute providers were rated requires improvement or inadequate by the Care Quality Commission. Now that wasn't good enough. These are ambitious providers want to deliver a good quality of service for patients, and that wasn't quite right. And I think quite rightly the then Secretary of State Jeremy Hunt, who obviously had a big focus on safety, called that out. Said, look, you need to do more. There's obviously the context of the Ian Patterson case, which was both independent sector and NHS, but quite rightly raised some questions around clinical governance in the sector. And over the last 6 years, and I think, again, we've been able to hopefully play a part in this because we don't compete on safety as an industry. Some things the sector can compete on, but not on safety. That CQC performance, and despite recent trials, we're very supportive of the CQC and the single word rating system. That's up to over 90% now. So there's been real investment there. So I think the message back to the NHS is, look, we are responsible citizens. We know there's more we need to do in certain areas. We want to be offering the very best quality of care, so you can be reassured about that it's safe and effective. But the quid pro quo to that, Matthew, is involve us. So in those local systems, particularly for the bigger and established players that are contributing significantly to service delivery in that patch, don't see integrated care as the preserve of the public sector only. Make sure that you're bringing those other organisations into planning, into discussions. Quite understandably, on some levels, not being on the board of an ICB is something that legislation rules out for a private provider. But beyond that, absolute freedom to involve the sector in what's going on. And I think that's the quid pro quo that I would always ask for as we look after our side of the aisle, just making sure that it is the integration is defined in that holistic way.
And I guess some of that's also a level playing field issues, isn't it? So actually, going back to your point about ophthalmology, great. But training does slow down the throughput for a consultant or a senior doctor or an AHP or a nurse undertaking that work. And that's always the accusation, isn't it? That actually the NHS therefore bears the brunt of that, go back to productivity, etc., and therefore you get a higher throughput. So that could be an interesting conversation about sharing the burden on actually it's in our joint interest to do that. I guess another observation, because in previous series, a podcast, I did a podcast episode with the Care Quality Commission, then Chief Executive, and they obviously regulate all kind of healthcare, including all your members who will have to be CQC regulated. I'm right in thinking, though, that, for instance, go back to this series, Ramsey Care wouldn't be assessed as an organization. They would only be assessed as individual units, whereas in the NHS, we both do the services, plus we have a rating for the organization itself. Is are they well run? Are they well led, etc.? What's your view on that? Because going back to your point of where leadership fails, we get poor quality of care. How do we know in the independent sector then if we've got a failing leadership or leading or failing organization if all we look at is the manifestation of individual services going wrong?
Yeah, I think it's a very good question. I think what you're expressing there is to a degree the difference, I suppose, in the way that the independent sector is structured versus large parts of the NHS. I'm from Lincolnshire originally. My family still live there. They're interested, frankly, in the quality and performance of a geographically proximate, NHS trust, community trust, mental health trust. Because they'll be the services that they experience. I think in the independent sector, if you've got like Ramsey, you've got 30 hospitals, there's others with more hospitals than that. Actually, again, going back to my family experience, they're very interested in what Circle Lincoln Hospital is rated, because that will be the hospital that they will use. They're not terribly interested in what a Circle Hospital in the Southwest is rated. So that's valuable. But you hit on a really important point, which is actually how does the regulatory system ensure that the leadership that sits above all of those individual sites is factored in? And we've done some work actually with CQC, and we're keen to expand this, which is to say, well, look, CQC don't necessarily rate Ramsey UK, it won't necessarily rate Circle, but it will absolutely understand its systems, its processes, the oversight it deploys onto those hospitals, and to a degree that will then filter down into any individual inspection and assessment that's done of a site. So if CQC is concerned that an individual provider's head office and its national and regional systems are not fit for purpose, and that will make it much more difficult for any individual site, or that little bit more difficult for any individual site to get top marks, as it were. And I think it's just about reflecting those differences, still making it meaningful for patients, so that local service that you are likely to use, you still understand the good, the bad, and the ugly about that site, but it is acknowledging that in a way that's different to the NHS, there is a sort of superstructure, if you like, a head office and a set of systems and processes which will massively impact on the quality of care that those sites are able to deliver.
And then that encapsulates the problem or the complexity that CQ's Care Quality Commission have as a regulator. Is primarily they're there to be the mirror for the public to say, is, as you just said, is Circle Lincolnshire great, or is the United Hospital Lincolnshire great organisations? Can I trust them? Can I trust my local care home? Other people might be interested in, well, what's the impact on the parent group on that local unit? Because when I listen to Michael West, which I always listen with interest, Michael will very much talk about actually that board and that guide in mind of an organization should and must have a serious impact on the care that's delivered in any unit. The same must be true for independent healthcare. And I feel sorry for the CQC sometimes, because actually they've therefore got some limited value in saying, I'm not convinced about you as a parent organization if I'm not even kicking the tires on them.
Yes, I think that's right, and board to ward, might sound a bit of a cliche. I know everybody sort of focuses in on that. Is perhaps that bit more? It's just a bit different, I think, in a independent sector provider, where there's maybe more tiers. But I think there's also an opportunity for more standardization, for more consistency, for more learning from best practice. Certainly all of the, I've certainly been to Ramsey sessions, but other providers as well, where they bring all the hospital directors together, their teams together, share learning. Certainly when there are, in the rare occasion there's a never event or something goes wrong, which we know does happen, that learning gets shared within the organization. That's nationwide. And actually we've picked up an initiative where we take that and share that within the whole industry as well. What happened, what learnings are there from that, and how can you avoid that happening in the future? So you want that spreading like wildfire so people learn.
Well, again, good benefits of your network in that respect. Let me just turn to one other area then. I was intrigued by the conversation with Keith Clintworth about Vitality, because they're quite a different organization. But I was fascinated to listen to, I think, two dynamics. And this is a kind of issue of what the NHS could potentially learn from the independent sector. So I thought how he described them understanding how well they were operating. So really using, live patient feedback, data on clinical outcomes, the objectives and the initiatives that every individual person plus their team were given, and saying, actually, how do I know what we're employing outstanding consultants, outstanding doctors, outstanding therapists? I thought that clarity was really impressive. And I have no reason to think that's not true. So, he was talking about that. And the second element was about what we could learn about how the insurance model incentivizes people to look after their lifestyle and make behavioral change. So it seemed to me they had huge knowledge about making behavioral change. He was talking about, to break a habit, it takes 7 to 10 weeks and change. And they do that through their approach because it's in their interest for people to be healthy and not in ill health, and therefore costing them money. So there was a pecuniary drive there. But if we apply that to 1.4 million working in the NHS, and you just talked about 160,000 people working in the independent health sector, actually, I kind of sit here thinking, well, why wouldn't we have a radically different way of supporting our staff to be healthy and helping to incentivize how they are healthy? Because actually, that's a good thing. We want to do that for the whole population. Why wouldn't we start with our own staff? And I suppose both of those things are, David. What else? What's your reflections on those? But what else can we learn from the independent health sector that you see that actually is very adaptable for the kind of core rest of the NHS and healthcare world?
Yeah, I think it's to a degree, Matthew. I think it's a UK healthcare question. There are so many benefits to the NHS, and I'm personally a very big believer in the NHS. And whilst obviously public satisfaction with the NHS is at record lows, commitment to the model remains very, very high. So I think there's many positives. One of the downsides, though, as it may be against other models, is the extent to which insurance-based systems, of which we have, I think now about 13-14% of the population covered by private medical insurance, but obviously internationally you have insurance-based systems, is they can provide a degree of incentivization and flex, which says, look, if you do this, if you demonstrably exercise more, eat differently, we can use kind of modern monitoring and wearables and all the rest of it to kind of track that. Then your premium could go down a bit. You pay a bit less. It's in your interest, but also it's in our interest because our calculation is that we're less likely to then need to fund treatment. And of course, the system that we have within the NHS sort of makes that much more difficult. But I think, given Secretary of State's quite right to want to say, look, we need to move from sickness to prevention, we're going to have to, I think it's an opportunity for the 10-year plan to think creatively about how we say, well, look, the NHS model is here to stay. It's brilliant. It's got many, many benefits. But are the things we can pilot and try, expand? I know that parts of the NHS have been looking at this to say, well, okay, look, we will help incentivize you to sort of eat differently, to exercise differently, to live a different kind of lifestyle, because we know we are an unhealthy nation. Fundamentally, all the indicators in Ara Darzy's report, I think, quite rightly pointed this out. It wasn't just a report on problems with accessing NHS services. It also a report, frankly, on the health of the nation, which was not a particularly kind of good write-up. So I think there are definitely things that we can maybe take from the private sector providers and insurers to say, well, what works for you? What have you seen? And Keith touched on a number of these in his podcast. And let's think creatively around how we could apply that into the NHS, and I think at neighbourhood level, again, that provides a real opportunity to understand particular demographics, understand particular needs, and get into that, and therefore try to encourage that different behaviour. It won't be easy, but I think it's the only way into the prevention debate, which actually is the only way really long term of making the NHS sustainable, because if we continue to be as unhealthy as we are as a population, the spending requirements will just become totally unmanageable. And so I think there is that learning, but I think there's also probably international learning as well that could be taken to see how we can try to deploy some of those things, both for patients directly, but also for staff who are going to be in short supply on an ongoing basis, and who we need to be as motivated, driven, and healthy as possible.
And I think it's how you do it, isn't it? I can't believe that the financial benefit of someone who wants to keep their insurance premiums down, where they're buying their own healthcare insurance, is the only kind of issue that forces someone to stay healthy. I just don't believe it's that rational a decision of, oh, I will save money if I do that. There has to be more involved in there, which kind of gives me a bit more optimism that some of the expertise in people like Vitality and others must be applicable. Because I know Keith talked about health checks, tracking activity, using prompts and incentivizing rewards to make that change. That just seems barnstormingly sensible, doesn't it, to actually do that? And if I think I'm a trustee director of Cambridge United Foundation, which is their kind of their foundation into the community, and Cambridge is not all affluent. There are some real deprived areas, and they've done some really great work on weight management with people in the most deprived areas, using sport, using prompts, using health checks, using activity base, and people losing 10% of their body mass because it's the right thing to do. That's kind of one of those government mission issues that we need to bring all the ambition and knowledge together at both, and get over the fact that it may be from an independent sector or from an insurance model, and actually think how we can adapt it, because that's going to be the way we make change, isn't it?
It absolutely is, and I think a lot of that comes down to health literacy. I think I hear the sector talk regularly around health literacy. Where insurers, the good ones, I think, are really good at understanding their patient, their customer, and communicating with them in a way that allows them to manage their own care, gives them resources, supports them, maybe online tutorials, all of this information. Because I think you're right, for a lot of people, they want to live healthy lives. They want to, whatever age and stage they're at, want to be able to live life to the full. I think a lot of us know, frankly, when we're not doing that in the way we should be doing. There may be reasons for that, but how can we be supported to act differently in a non-blame environment? And a lot of that comes down to health literacy, and understanding how we go about making change. I think the NHS does some really good work in this space, as does the private sector, but we absolutely need to turbocharge that, and it needs to be, and again, learning I've seen from our sector, it needs to be regularized, it needs to be ongoing, being almost, we talk about partner to the NHS, being a partner to the patient to support them on their journey. So it's not just a sort of one-off episodic intervention and then disappears off again. Actually, it's that kind of ongoing commitment, and primary care is a big resource in that space, community service as well. But it comes down to that health literacy for me, of how we, educate people to live the healthiest possible lives.
Fascinating, David. So as we come to the end of this episode, what thing looking forward, and you've mentioned a bit of optimism, things are changing, but what are you looking forward to in the kind of next stretch? New government, not so new now, but newish government, got a 10-year plan for your members, for how we move forward. What are your hopes, and I guess, what do you fear most is not going to happen that you would like to see?
I think the big danger for me with the 10-year plan is that we sort of engage with that individually, people sort of, but we think there's not much we can do between now and then we look to it and delivery and all the rest of it. And I think particularly with regards to providers and sectors working in a different way, in a more collaborative way, we could start that now. frankly. I think asking the question around how we can engage more constructively in local systems to get through winter, because we know we're facing a difficult winter. Yes, national planning is helpful, but frankly, local planning matters much more. And what can we just get on and do now, which will clearly then support whatever comes out from the 10-year plan? Because I think there is that danger within I think all of us in healthcare, that we kind of look up and wait sort of for that direction, and I'm sure it'll be a very comprehensive exercise, but actually day to day, in terms of driving service improvements and making sure patients are getting the best possible care, it's those local interactions, the local partnerships that I think really deliver that, and we can do that today. We don't need to wait for a plan.
Well, David, it's been fascinating to talk to you, and in this kind of series, to hear the insights from some of the leaders from the independent healthcare world. We've talked about just now, the similarities, between the synergies between the independent health sector and the NHS. We've talked about the similarities in approach in supporting our staff. We've talked about how things might need to evolve and develop, especially about training, development, and people being more interdependent upon each other in local areas. And then that final bit about how the government mission of being preventative, etc., needs all of our skills and energy to actually do that. I thank you to your network, the Independent Healthcare Providers Network, for facilitating us talking to the independent sector and getting their viewpoint. And thank you, David, to you for sharing your insights. And we look forward to more collaboration as we go forward on all these areas.
Thank you, Matthew, and thank you for doing it as well. Hugely appreciated.